Sharon Sternfeld is going to do that. Is that right, Sharon?
Hi, sorry. After the screen moved when you guys stopped sharing. Yes, so I'm going to start with a few questions for Howard, and then Michelle Dern and Howard will be helping us with our other two speakers. And I'm trying to find, I summarized, but I pretty much know what it says. So Howard, there are so many questions about the testing for COVID. So we needed a clarification of PCR versus antibodies, reliability, and periodicity. Good luck.
Okay. I didn't talk about antibody tests because they are pretty much useless. If you get a positive, it doesn't really mean you have the coronavirus that we're all worried about, the SARS-CoV-2. And if it's negative, it doesn't really mean that you didn't have it. So right now, we don't recommend that anybody get the antibody test at this stage for just general curiosity. As far as the reliability of PCR in general, it's going to have fewer false negatives and positives than most antigen tests. But each company, each manufacturer and lab has had to do some studies on this. As you can imagine, PCR has to be compared to the disease, when we know we have the disease. Antigen is often using PCR as its gold standard. So they're kind of evaluated in different ways. But you would have to look at each lab and each manufacturer, and then you also have to kind of check. A lot of the ones have, done this on like 20 patients, which is, to me, is not a great study. And yet they're saying, oh, we have 98% sensitivity and 100% specificity, etc. So I can't say too much that's promising with reliability of the antigen test at this stage. As far as periodicity, how often you would do the testing, I try to deal with that in my talk, but again, you want to do it more often if there is a high rate of disease in the community or in that school, and you can really slack off if there are much lower rates in that school. Again, there's nothing wrong with over testing, excepting that it's very expensive. And so I think that schools eventually will start adopting a periodicity that maybe matches the community or their local school, how many community outbreaks, etc. There are many schools that have started programs either with UCSD or with some other labs. So I would say I know of about 15 schools or school districts that have done some form of screening tests. And it'll be interesting to see, how it was done, what their costs were, how quickly it was able to, people were able to be pulled out when they were positive, and how quickly they were able to get through the tests, if it was a nasal sample, etc. So we're looking at a lot of the schools that have already started that.
I will just add that there is this county-wide C3 program linking Rady Children's Hospital, Children's Primary Care Medical Group, and the county testing sites, where every child at every sick visit, every well child is being offered a COVID test, the front nasal type, not the nasopharyngeal. And we offer printouts for them to offer for their school notes, especially right now, we're ruling out a lot of had diarrhea for one day. So sorry, I just threw that in. So if your patients go there, you can send them to us for testing. And Dr. Terrace, the next question. We are already receiving medical waivers for students to not wear a mask. Please advise. Student has an IEP and gen ed teachers have plexiglass face mask and face shield available.
Well, so I can see that there's several other people on this in the audience here who are probably grinning like Dr. Tom Coleman and Susan Barndollar and Kareem McCarthy, because usually when we're on a conference call and we get this question, I ask them to answer it. And now here I have to answer this. Let me put it this way. There is no really safe way to have a child without a mask inside a classroom with other children and other adults there. Adults who are working closely with that child can wear, N95s, etc. But the other students in the classroom cannot. So the best place for children without masks is going to be in an outdoor classroom, which means a tent with at least two sides that are open. If that's not feasible, then you have to decide how much risk can your school district accept for other students in that classroom. You can mitigate these by having great ventilation in the room. You can put the input side of a room air cleaner that has a HEPA filter. You can put that near that student, between that student and other students. All those things will help lower the risk of other students being exposed to the unmasked child's aerosol. But I can't promise you that you're not putting some risk there. So I would encourage those schools that want to bring children at this stage of the disease without masks onto their campuses, that they try to encourage their school administrators to put heat lamps in tents or electric heaters in tents that have two sides open as the safest way, limiting the amount of time if that child is indoors. Sure, barriers and all those other things, you can do what you can, but you can't say that you're lowering the risk as much as if all the children had masks. So there's no regulations. It's your decision of your school district and how you decide to manage that.
Thank you, Dr. Terrace. I think we'll move on to the next questions for Dr. Sawyer, if that's okay.
Please do.
Okay. Dr. Sawyer, are you ready for a question?
As long as they're not about wearing masks in school.
Okay. There was a couple questions about side effects of vaccines, and you answered a couple of them in the chat box about HPV vaccine, but there was a couple about flu vaccine as well. One question was about any danger in getting a yearly flu vaccine over time. Maybe that question is related to preservatives or things like that. And then also a person who's had a large local reaction to the flu vaccine and a future vaccine with that.
Right. There hasn't been any convincing reports of significant side effects from yearly flu vaccines, and some of us have had them for many, many years. I think there is some concern and some recent literature that you might not respond very well if you get a flu shot every year, but that's more on the effectiveness side than on the safety side. So the recommendations is still that people in high-risk situations for sure, and really everybody, should still be getting a flu shot every year. We are hoping to get a better flu shot that might not require that, but we've been working on that for a long time. There is some progress in that direction. With regard to local reactions, I mean, it's nothing unique about the flu vaccine. Pretty much any vaccine can have local reactions, and unless those are extremely severe, the recommendation would be to go ahead and repeat that vaccine. Some of you are familiar with the whole arm or leg swelling that we sometimes see with DTaP vaccine, and despite that, the recommendation is to continue vaccinating. There's no long-term sequelae from those local reactions. And then the last thing I did answer in the chat, but there's lots of misinformation about HPV vaccine and side effects. If you look at the real data, it's actually one of the safest vaccines we have. Certainly adolescents faint when they get in HPV and other vaccines too, but particularly HPV. But other than that, there really aren't serious side effects that have been convincingly linked to HPV vaccine. And if you look at the flip side, you're preventing cancer. So for me, it's a very simple equation if you look at the risk and benefit.
Okay, and just one more quick question about, have you seen any recent cases of pertussis in our community?
Pertussis is still percolating along. It's not been very active. There was a little blip in the late spring, early summer here in San Diego. I am concerned that because of that gap in routine immunizations, we may start to see more. And so I'm hopeful that we can react in time to prevent an outbreak of any of the vaccine preventable diseases by getting our kids caught back up.
Great, thanks. Is Howard going to ask the next question, or Sharon?
It's Howard.
Yes, okay, I can do that. The one first was, which of the rashes occur that you talked about there also occur in adults and not just children? Dr. Boyko. Oh, is Dr. Boyko still there? Maybe not. Okay, well, she did answer them in the chat. So if you guys were to check the chat, you will see some answers to that. It said, every picture I showed you can occur in adults as well as children. Nurses, look at these kids' hands and feet when you weigh them. If there's any concern for COVID, take off their shoes and check your own body too. The second question for Dr. Boyko was, what's the prognosis for these symptoms? Well, for pernio, they do start to go away after 7 to 10 days, and they do resolve without any permanent damage.
I'm trying to, can you hear me now?
Oh, now we can hear you, yeah. Sorry, we didn't think you were there.
It's weird, it's forbidding me to share my video, so you just get to see my smiling face there. But somebody had, oh, now my co-host has asked me to start my video. Terrific, okay. So, hello everybody. Just to let you know, I put in the reference for Mask Me Too, and my personal experience has been the cotton, if you're just like going to the supermarket or something, you have a cotton mask that fits you really tightly, it almost immediately gets saturated. And I find myself breathing through my mouth more than my nose because it's so hard to draw the air through it. And then that makes it even wetter. So if you can use a style that holds it a little like the N95 that tent it a little away from your face. And if you feel that it's wet inside, if you have the opportunity and the extra masks to swap it for a dry mask, that'll go a long way to help.
Okay, I think that was, you did a great job of answering the chat questions for us. So I think we'll move on to Dr. Jindal in respect to everyone's time. There was a question that was multifactorial. I think you answered their question about what genetic and metabolic testing, but specifically with the neuroimaging, they wanted to know MRI with or without contrast, and do you rule out traumatic brain injury?
So MRIs I generally get with and without contrast, because what I'm usually looking for is there any sort of neurodegenerative process, any sort of things affecting the white matter. And sometimes you'll see that on a contrasted study. To be honest though, you probably don't need it. So if there's some sort of contraindication or a parent is a little bit against using contrast, you don't need the contrast. I think most of the time I just want a child sedated once. And so I want to get as much as I can during that time. And so I think the highest yield is with and without, but most things will show up without contrast. So not necessary. For TBI, that is also more of a clinical diagnosis. So traumatic brain injury, you don't necessarily see something show up on an MRI, especially years down the line. So a lot of parents will ask, hey, my child fell at the age of 4 months, to the floor. And could that have caused the autism, or could that have any significant impact on his neurodevelopment? And usually no, to be honest. And usually we get an MRI like 4 years later. Maybe we'll see a little bit of scarring, maybe if there had been a bleed there, but you don't really see any long-term consequences from injuries that were rather mild. Now, if it's a child that has significant TBI, skull fracture, a lot of bleeds, yes, you'll probably see something. And yes, maybe that's related to some developmental issues, but I think that's a little bit of a separate case.
Next question. Many children with autism get sleep studies. Can that sleep study screen their EEG, or do they have to have a separate EEG to diagnose seizures?
It can be a screen. So part of the sleep study montage, they'll do what they call an EEG montage, where they'll do, you saw in one of the images that I had a lot of squiggly lines on there, but during a sleep study, they'll have maybe 2 or 3 of them. So it's a good screen. It doesn't replace a really full EEG, but if you don't have significant concerns, if you just want to know, hey, is their brain activity okay while they're sleeping? I think it's fine to start with that as part of a sleep study. And it's good enough that you can get information from it. If there are any concerns on it, usually there is a sleep medicine physician reading it. And if there's any concerns that it's really abnormal, we can always have one of our epileptologists or EEG readers take a look at it as well, if they can get access. Or if there's a little bit of an abnormality, then I'll probably just refer them for the full montage at that point, but it doesn't hurt.
All right. I think we had a wonderful conference this year, and we so appreciate all 4 of you helping us out and educating us.